Hi, good morning. I think we'll get started. My name is Dr. Quek from Singapore, and this is Dr. Jiang with me today. Thank you for getting up so early in the morning to listen to this lecture. I guess first up, I'll pass the mic over to Dr. Jiang.
Yeah, I'm honored to have the occasion to introduce Dr. Quek. He's an expert in the radar frequency ablation, and today we have the opportunity to listen to the lecture concerning the qualitative option for the management of the metastasis of the spine disease. Please.
Thank you. Thank you for a kind introduction. Boom Pao is a very dirty place. The count of pictures are really nice. I went to a few sites yesterday. So today I'm asked to talk about percutaneous options in management of metastatic spine disease. So before I begin, just a short introduction of my hospital. Nanjing Hospital is near the city center. It's a 1,700-bed facility and one of 3 hospitals within the National Healthcare Group. The hospital is sited within the cluster of hospitals, which include the National Neuroscience Institute, National Center for Infectious Disease, and National Skin Center, a private hospital just across the road. So if I get too angry, I'll probably just walk across the road. Okay, moving on, this is our entry suite now. We've got the Siemens Geno, it's a floor-mounted CT robotic arm, and recently just added the Philips Azurion, which has the IVUS capability for vascular work. Okay, so moving on to the topic at hand, metastatic bone disease. Most common site of metastasis is the vertebral, pelvis, femur, and skull, with vertebral taking up to 69% of the metastatic sites. And the median time from cancer diagnosis to bone metastasis is 30 months. This is a very simplistic way of us looking at treating metastatic spine disease. I'll go into more details later, but really we're looking at oligo metastasis. Oligo means a few. Metastasis recurrent or progression versus multiple sites where there's mobility issues. Our approach is slightly different. Let me just briefly recap about the evolution of concepts of cancer. So just a brief background. Early in the 1900s, Halstead described the occurrence of a tumor and then the hematologists spread. So that gave rise to surgical oncology, where you just engulf, dissect the tumor, take out the whole tumor. Okay? And then after that, in the 1970s, Fisher talked about systemic theory, where it's kind of binary way of thinking. So you either resect or you have widespread, which is systemic. So that gave rise to oncology, systemic chemotherapy. And then in the late 1990s and 95, Howard talked about a spectrum model, where there's an intermediate form of local regional disease, and the words oligo metastasis and oligo progression is coined. That gave rise to the whole field of surgical mastectomy, as well as radiation oncology. As you know, in the last 2 decades, interventional oncology is creeping into the space and established itself as a minimally invasive form of treatment, where we can treat these patients and overall affect the overall survival for these patients. So just looking at this, when you have oligo metastasis, then the intent is often curative, as much curative as we can, so we are more aggressive. But we are dealing with multiple sites, it's often the referral that we get, and we need to educate our clinical colleagues a little better and get early into the guts of the case rather than for it to be widespread. Tends to be more palliative. So now fleshing out more meat into the whole skeleton. This is a paper published in Oncologist by the Spine Disease Multidisciplinary Work Group, and basically it allows interdisciplinary referrals by providing physicians with straightforward recommendations regarding available treatment options, including emerging modalities such as SBRT as well as percutaneous tumor ablation. So let me just take you through this very simply. So this comes back to no fracture and fracture. Alright, and after that further, subdivided into asymptomatic versus symptomatic, and unstable versus stable. Just a short term of fracture. This is where you need to interface with your spine colleagues, and they tend to use this is a de facto standard where this is spinal instability neoplastic score. And what it does is look at a few factors. It looks at the location, the positional factors, the type of bone lesion, spinal alignment, as well as upper body collapse, and whether the postural lateral spine elements are affected. So the score of 13 to 18 is unstable, and you really need to involve the spine surgeon in these cases. Alright, so don't just willingly just go and do the procedure. Now, in the spine literature, you're always looking at the classification system, and these people look at the prognostic value of this classification system in terms of the risk factors involved. And they found that the bowel and the oscillatory spine, these factors have the most, index index, have the most accurate prognostic predictive ability. And there's a growing trend in the studies to design the customized scoring system to the individual cancer pathological subtypes. And again, since the spinal instability neuroplastic score, which I mentioned earlier, was described and is reliable, good reliability for predicting instability amongst the surgeons as well as oncologists. So it's kind of the scoring system we use as well. Now, moving on to the second kind of differentiating factors between all these patients, what do we look at once we classify fracture, no fracture, stable, non-stable? We look at life expectancy. If life expectancy is less than 6 months, then this is something that we will not go aggressively. If it is crosses the threshold of 6 months and your oncology colleagues say, yeah, it's a good 1 year or so, then the quality of life becomes important. And that's where we go in and become a lot more aggressive with what we do, because it's not without risks. Okay? And other factors, of course, performance score, which is tied quite closely to life expectancy, as well as whether there are many versus few visceral metastases. So, for patients, just a side note, for uncomplicated painful spinal metastasis, the first line is still pharmacological, oral analgesics, or other non-pharmacological techniques, but not to the extent where you can't intervene. But that's where we do as first line. Then the last part, which I've shown here, called compression. So that one we have no role in it. Certainly, that's not something we would do. So basically, to sum it all from A, B, C, D to E, ablation in all cases except without fracture who are asymptomatic and life expectancy less than 6 months, patients with unstable fracture, verbal augmentation in all cases except cord compression, and SVRT in all cases, surgery for unstable and cord compression. Just kind of like quick summary. So when you look at these things that we just mentioned, look at the principles, right? You have to call it the stabilization part, which is important because that comes with stabilizing the microfractures from moving against each other and causing pain, and you're talking about treatment. So surgery can cover both arms. And I think over time, interventional radiology itself allows us to cover both arms as well. So now looking at the label published in 2020 by the Society Standards for Practice of Thermal Ablation of Bone Tumors, few technical considerations we can see there. We talk about protection, so when we do it, we have to do displacement with gas, with fluid hydrodissection, monitoring and active with somatosensory evoked potential or motor evoked potentials, or passive, just putting a thermometry or thermometer in the spinal canal or near the nerve root that you will potentially be touched. Consolidation is important, using both cement or hardware, and utilization of pain palliation, reduce blood loss or reduce heat sinks. In combination, as you are discussing the case with ablation oncology, sometimes ablation can be first, or in fact you can promote that as an immediate pain relief, because it takes a while for them to go through the whole cycles before they can get the ability to relieve the pain. And of course, there's the risk of fractures without having us to do the consolidation part. Radiation first would be something that you consider in patients where there's epidural involvement, because we can't get into that deeper layer in terms of doing our techniques. Or if there are small tumors, perhaps radiation is something that you can do first. And then, of course, you can say that you can do that first, but this said to me, I can consolidate for you with cement. So these are ways to convince the colleagues to send to you. Now, moving into tools on interventional radiology, what do we really have? So I've talked about one at the bottom pretty much in the previous slides. From the imaging perspective, we have cone beam CT, and then we have CT fluoroscopy. So these are the two tools used in imaging for us to help us. This is a straightforward case of pre-op analyzation as requested by a spine surgeon. 62-year-old Chinese female, metastatic breast CA to spine, and I'm sure most of you are familiar. You can see that on a sagittal axial view, there's quite extensive involvement of tumor. The surgeon wants to go in and do a corpectomy and do an en bloc dissection. So we reduce the blood loss as per their request with both embolics as well as poise. Important to look at the level above and the level below because of sensitization and how the blood flows when you're doing a procedure like this. And the procedure was done, the surgeon was really happy, minimal blood lost. Now, just looking at imaging, what we do now, take a few cases to how we utilize them. Here's a case of a 66-year-old Asian male with IgA multiple myeloma and a thoracic pain at T9 and T11. As you can see, there is enhancement, there's a hyperintensity and inversion recovery, which is in T9 and T11. And this is something that we've done up for the last decade. We use the cone CT to assist us, and it is good because it's like kind of like allows you the opt-in trajectory, not just purely axial. You can draw the line, you spin the patient, and then you can follow through, make sure your line is always through the pedicle, and that allows you to then, with this, be able to position the kind of the trocar or pivot needle in this sense in the entry view, which is probably not shown very well here. We like to use the entry view versus the progressive view because that allows us to look at the left, right, up, down, so it fixes the needle quite nicely. And then once you engage bones, you're pretty much home free in that sense. So once we're done, we get into the trocar, we prepare the bait with a drill, kind of like allowing other instruments to go in, like the balloons or the cement later. This is the osteocal system, the bottom right trocar. There's a different color gradings. And what is important is it allows us to then decide how big a ablation zone you want, and allow us to then put the right probe in there. So for this patient, once we finish the ablation, which is primarily a RF radiofrequency system, we follow the kypho and enter with cement. And the patient was able to walk post-op day one, which is good. Now, technique utilizing CT. This is a case referred from private to me. 64-year-old Asian male, man studying NSCLC, has back pain, good expected life expectancy more than 6 months. Patient is still on riding motorbike, in Indonesia, and had multiple RT sessions before, but there's now reduced tumor sensitivity. And of course, we have talked about spinal cord tolerance. This is a term in terms of cumulative tolerance of these structures like spinal cord, radiation oncologists call this familiar. So I think they reached the limit of what they can do. So refer to us and see what we can do. So we can see this PET CT, you can see that there's a metabolic activity seen in L4 and L1 regions, and also retroperitoneal involvement of the tumor. So our plan was to do ablation of retroperitoneal rodent mass, L1 and L4 metastasis, followed by kyphoplasty of L1 and L4. So this is the part where we look at algorithm. This is uncomplicated, painful spinal metastasis. Patient has gone for SBRT. It has worked well for a while, and then how do we move on? And I think at this stage we can come with ablation and verbal augmentation, which is bleeding. And what we did was, I'll show the scan later, but it's a bit like when you do under CD falls, it's all kind of enhanced and you can't tell where things are. So to be mindful and be careful, not transgressing any big structures, we decided we would put in an arterial catheter. We published our smart box transradial access in JVR a few years back, and this is what we do. So we put a transradial access, distal transradial artery. You can see the picture of catheter. And I wanted to mark where the venous site is, so I put a catheter up as well, but unfortunately I couldn't get it all the way up. I think chronic compression, thrombotic atresia, we're not sure what has further tumor done to the venous site. So this is what we see in the CT suite. You can see the uncontrast view. This is what it is. If you get right down, you can't really see what's happening to a big mesh over there. So what we did was we loaded up the CT scanner with 10 mix of 50% dilute contrast. And then each time we press the pedal, we didn't press the pedal for CT cross, we tell the radiographer, you just now inject the contrast. And they do it, and then we give a 20-second delay, we press the pedal, and then we could then see some of the structures line up fairly nicely for us to intervene. And that's important because you see further down, we see where the aorta is, right? With that, we then have more gumption to be able to then place our needles where we need to place in terms of cryo probes to ablate the retroperitoneal tissues, as you can see over here, right? And then you can then monitor the ice ball quite nicely on CT. Then for the rest, it's very straightforward. It's just fine. Just use the osteocal system by a particular approach and anticipate both L1 and L4, sighting up with the ablation flow chart. And this is just going at this long procedure, so we're not going at it. You can see the snap off access with the arms sticking out, and we chose that because it's easy when the hands to put in, and it's just pure transradial access, as you can see over here. So this is where we can see the prior probes at retroperitoneal mass, the osteocal probes at L4, and this is the post-intervention images. And patient discharge on day 4 with reduced need for back brace and increased mobility. Now, multiple level, using spine stents. We talk about cement, we talk this a little about hardware. And again, this is a 69-year-old lymphoma patient with multiple level involvement, back pain, opioid resistant, complete power. And this case, we've got our new spine surgeon involved with us, and he was the one disabled, multiple levels involved, let's go a bit more aggressive. So we put in our 7 stents in these patients, and within 2.5 hours. So actually, we gotten really good at it halfway through because we realized where this figures will start working extremely good. And because it's a unique particular approach, we didn't have the time is cut by half. We managed to be able to get to cross the midline and therefore put in the cement, and 5 hours later, the patient is walking. So from big bump to walking, so it helped this patient significantly. How about high-level thoracic involvement? So again, we use CBCT for this. Here's a 70-year-old Asian male with metastatic urothelial CA to T3 and T4, new onset right shoulder pain, neck pain comes and go, but when he has very significant 10 on 10, exacerbated with shoulder extension, prolonged lying, and basically just affecting quality of life post-sleep. Okay? So it started escalating subcontinental with breakthrough pop-ups and oral gabapentin. As you can see from the surgical MR contrast, you can see it's quite extensive tumor, even the axial going on. So the goal for this patient is the extensive tumoral involvement, more than 3 cm. We're looking at just palliations. And what we did was we went in using the ĐQCT, which allows us to intervene at a higher thoracic level. And post-intervention, you can see the images. Patient was discharged 2 weeks later, and on aspirin body frame, and pain simply improved with good pain control. So that's what the palliative physicians are looking at, trying to control the pain, because sometimes they feel that there's only that much they can do with pharmacological interventions. Moving on neuro monitoring, we talked about it earlier on. I'm sure those who have this space will have seen these 2 tables. And one is on motor evoked potential, and also talking about somatosensory evoked potential. And basically, over here, MEP is kind of like there's a decrease as seen. It's close to 100% sensitivity and 70% specific for the detection of motor deficits. So here's the case that we have. 63-year-old, we started this program and it's kind of like picking up steam now with a 63-year-old Chinese female with urothelial malignancy, oligoprogressive disease. Right T-shot particular regions, FTG added, and also left fifth involvement. So the radiation oncologist said we'll shine that part, but can you help us with that part? Then the spine bone. So we had no problems, we went ahead. But certainly, if you look at, when I talk about other systems like osteoCo system, those are looking at treating tumor pretty much in the anterior tutus. But when you look at osteowanted, it's kind of a critical zone. If you're not careful with the ability to be unfamiliar with the abrasion zone, you can and you will potentially damage the spinal cord. So in this aspect, we come in, we know that the tumor is way at the back. We have to kind of like be aggressive in what we do. We want to ablate as much as we can, and we want to inject the cement. So in this patient, what we did was we do hydrodissection, but it's not adequate because it's really near the spinal cord at the T-shaft level. We also put in the tomorrow, but then again, that has limited placement based on where you can find a space to put it in. So in this respect, we went on to do neuro monitoring, and this is a lady with transcranial probes at the top, which sends electrical impulses, and you got electrodes positioned over the muscles over the thigh. And you could see that during the procedure, once you place the probe, it fires and the patient is moving, and that's when you detect the movements up and down. And in this person, there is actually a motor evoked potential drop of 80%, and the somatosensory latency has increased, and drop of 20%. So we kind of like covered the patient at this stage, we move on to consolidations. Patient was discharged well, without any motor deficit. So I think in that aspect, it's good safe. It's good to have something like this. You have to do something that's high risky, because otherwise don't do it, right? Because you cause more damage if you're not careful. So coming to the end, I will spend my time. In summary, understand the principles of stabilization, utilization of various imaging tools, MRI, thermal, primarily osteoCo is on target, using cryotherapy, consolidation, kyphoplasty, thermal, or neuro monitoring for high-risk cases at risk or call. Thank you.
Wow, excellent. It is a success. A lot of techniques we could not do in Vietnam. It is a just we learn from the presentation. And we ask the Q&A at the end of the session. And